Today we have Dr. Kagan Ege Karakus, MD, coming to us from the Barbara Davis Center for Diabetes in Colorado. Title of his talk is Tirzepatide Use in Type 1 Diabetes. Dr. Karakus graduated from Koç University School of Medicine. I believe that's in Turkey, and is currently a postdoctoral research fellow at Dr. Aaron Michael's lab at the University of Colorado Barbara Davis Center. His research focuses on type 1 diabetes, specifically T-cell receptors, and clinical studies on diabetes technologies and GLP-1 analogs. Thank you, Kagan. Thanks so much for joining us. We're very excited to hear your talk. And if everyone could drop questions in the chat and we'll take them at the end of the talk, that would be helpful.
Yeah, thank you. Thank you very much. I hope everyone can see my slides.
Looks great.
Yes, today we are going to talk about tirzepatide use in type 1 diabetes. First of all, I have no conflict of interest, and as I will be talking about tirzepatide use in type 1 diabetes, this is an off-label use. So let's start with tirzepatide. We know that it's a GLP-1 and GIP receptor agonist. It's a dual agonist, and it's a once-weekly injection. So we always start with the lowest dose, 2.5 milligram, and we can increase up to 15 milligram. We know that previous RCTs show that the weight reduction is dose dependent. And we are doing this, we are starting with the lowest dose because there are GI side effects, adverse events like nausea, vomiting, diarrhea, constipation. In order to prevent those, we start with the lowest dose and increase those every month with 2.5 milligram increments. So when we look at the effects of tirzepatide, we know that it affects gut-brain axis, and it increases satiety, decreases appetite, food intake, and also it delays gastric emptying. So these are really important effects that leads to weight reduction. It also increases insulin secretion and decreases glucagon. We know that it improves metabolic parameters like LDL cholesterol. It decreases liver fibrosis. It may decrease liver fibrosis, and it has cardioprotective and renal protective effects. So in general, it affects multiple systems. Because of all these, actually, tirzepatide is definitely a hot topic currently. Last week, while I was preparing the slides, I saw that there are 548 papers out there for tirzepatide. However, when we look at type 1 diabetes, there are only 9 papers came out so far. And today I will be talking about 2 of those papers I contributed. So let's start with the first one. Excuse me. Yeah, this paper, it's actually the first retrospective observational study for tirzepatide use in type 1 diabetes. It was a single center study. We followed up 26 adults with type 1 diabetes and obesity for 8 months. So our primary endpoints were change in A1C and change in weight. And for secondary endpoints, we looked for change in BMI, time in range, time in tight range, and time above range. So we also looked for safety outcomes as well, because this was the first observational study of tirzepatide in type 1 diabetes. So when we look at our population, study population, as I said, we had 26 people, and mean age was 42 years, and mean hemoglobin A1C was 7.3% at baseline. Mean BMI, as you can see here, it was 36.7. There was just one person not in obesity or overweight range, but except this person, actually all of the people had obesity or overweight. They were overweight. So again, 77% non-Hispanic white and 54% female. Most of them were using insulin pump at that time, and only 27% were on MDI. So good thing is 96%, almost all of the group were using CGM, so that we were able to analyze glycemic outcomes with CGM. So let's move on to results. And here we had 26 patients who started tirzepatide. We looked for outcomes at 3 months, 6 months, and 8 months. During those time points, we had 25, 25, and 24 patients that were using tirzepatide at those time points. So at the beginning, at 3 months, 22 patients were on 2.5 milligram, which is the lowest dose. And, it looks very uniform, like all of them, almost all of them were at the same dosing. However, as the time passed, dosing really differed. For example, at 8 months, 7 patients were on 7.5 milligram, 7 patients were on 10 milligram, and others were varied, depending, the doses varied between those people. Reason of this, because it was a retrospective study, not a prospective one, so we didn't have a dosing strategy, and this was a real world data. That's why these doses are quite different. So let's look at our first primary outcome, which was change in A1C. And at 3 months, we saw a 0.45% reduction in hemoglobin A1C compared to baseline. And those people most of them were using 2.5 milligram of tirzepatide, which was the lowest dose. And then in the following months, we saw even greater reduction. At 6 months, for example, it was 0.56, and it sustained at 8 months. And our second primary outcome was change in body weight. And at 3 months, we only saw a small reduction there, 3.4% change in body weight. However, when we look at 6 months and 8 months, we saw that there's a clear reduction there, almost 10% reduction in body weight. And those people were using variable doses of tirzepatide at those times. So we really wanted to understand the relationship between change in A1C and change in body weight. So we used a mixed effect model, and it used data from all time points, and this showed us a significant association between hemoglobin A1C and body weight over time. So they were related. But then we tried to see if this relationship is just solely based on change in body weight. So we adjusted for the change in weight, and we saw that the reduction in A1C at 3 and 6 months from baseline was still significant. So there was effect of tirzepatide there for glycemic improvement, regardless of body weight change. And another analysis showed that 1% change in body weight was associated with 0.05% change in hemoglobin A1C. This also indicates more weight loss was associated with more reduction in A1C. So if people use tirzepatide, they will see some glycemic benefits. And on top of that, if they lose more weight, they will see even greater benefits from using tirzepatide. When we look at CGM metrics, as I said, 96% were using CGM. And from baseline, there was a significant increase in time in range. It increased from 58% to 70%. And this improvement sustained over time at 6 months and 8 months. And important thing here is time below range, because, we need to assess safety. We need to assess hypoglycemia risk for these people. And it sustained over time. It was 1.5% at baseline, and it was still at that range, similar ranges, 1.5%, 2%, 1.4% in the following months. And here in table 2, we put those results as numbers here. So we talked about A1C and percent change in body weight. And when we look at mean sensor glucose, it was 175 milligram per deciliter. We saw a almost 18 milligram per deciliter reduction in there, which is significant and important. Time in range increased 12.6%, 11%. And when we look at time in tight range, which is even a tighter range, which was 70 to 100 milligram per deciliter, here again, we saw 10%, 11%, even 12% increase, which is quite significant. And actually, the most important thing here to me, this percent change in total insulin dose per day, because usually we see glycemic improvement with increased insulin use if people have high time above range, like 40%. But still, they decreased their total insulin dose 21%, 23%, 24%, but still they achieved 12% increase in time in range, 13% increase, which is quite significant. And as I said, this was the first study of tirzepatide using type 1 diabetes. So we also collected safety outcomes. And as I said, there was no change in time below range, despite significant improvement in time in range and reduction in body weight. So one person had severe hypoglycemia event, and one person had severe constipation. And these two people discontinued the medication. And one person developed peroneal nerve palsy, which is foot drop. This is probably due to rapid weight loss. And there was no decay event during this 8 months follow-up. So to sum up the first study, at 3 months, the most prominent improvement was in time in range. It appeared first, and it followed by hemoglobin A1C. And we saw a great body weight reduction, 10% at 6 months. And the glycemic benefits can be seen with 2.5 milligram dose, which was the lowest dose, while the body weight reduction is dose dependent, which means that regardless of body weight reduction, we saw a glycemic benefit even with the smallest dose. And glycemic parameters improved while insulin need, body weight significantly reduces, which is important. And tirzepatide didn't increase hypoglycemia risk. So our data suggests that it was safe to use without any increased hypoglycemia risk. So from the first study, we learned that glycemic improvement presents early, even with the smallest dose. So we decided to investigate these glycemic changes further to understand how early it is. And so we wanted to see change in basal insulin, change in bolus insulin, and change in basal to total insulin ratio to understand what's going on there with insulin metabolism and really what's going on with the glycemic outcomes. So we did a second study, second analysis. Again, this was also a retrospective single center study. This time we followed up 11 adults with type 1 diabetes and obesity for 8 months again. However, this time all patients were using automated insulin delivery system, which was tandem control IQ in this study, so that we could collect insulin use, insulin delivered at those time intervals. So we collected their pump data, CGM data, and clinical data, and we analyzed it over 8 months and compared it with the baseline. And in this study, our baseline was tirzepatide initiation. When we look at the baseline characteristics of patients here, median age was 37 years and 64% were female, 91% were non-Hispanic white, and they had overt, very well-established diabetes with a median diabetes duration of 24 years. And their baseline A1C was 7%. And I want to remind you that they were all on this AID system. So that's why they achieved actually a relatively good A1C at baseline. And as you can see here, BMI, median BMI was 39.6. They all had they were all overweight or they had obesity. Okay, let's look at the results of the second study. So when we look at the total daily insulin, I know this looks a quite busy slide, quite busy figure, but let's start with the total daily insulin. So it decreased from 70 to 50s just within 2 months. Within first 2 months, we saw a significant decrease in total daily insulin use. And we also saw a further reduction in the following months at 2 to 3 months, 3 to 6 months, and 6 to 8 months. There was a further reduction in total daily insulin use. However, the most significant and the highest decrease was in first 2 months. When we look at basal insulin, again, we saw a very significant reduction just within the first 2 months and a further slight decrease after that. And a similar pattern here. First 2 months, the most significant and most prominent decrease there. Then it followed with a slightly further reduction. So since we had tandem control IQ data, we had chance to divide this bolus insulin into two types. First one was user-initiated bolus insulin. This is user-initiated, which means that these are entered by the people. So when they eat something, they enter their carb amount or they directly enter their meal boluses. So it's user-initiated. And the second one was autobolus insulin. This is automated insulin delivery. So the algorithm of AID system, automated insulin delivery system, if it predicts blood CGM glucose will be higher than 160, so it calculates a correction dose and it sends that autobolus insulin automatically without user interaction. So this is the correction dose the system, the algorithm sends. And here, when we look at the insulin doses for user-initiated and autoboluses, we saw a significant decrease within first 2 months for both of those, and a further slight decrease there after that. We also had the counts of those user-initiated and autoboluses. So let's start with the autobolus there. So system, we can say that system interfered less. It sent less correction boluses. Here, as you can see, it appeared there was a significant reduction there in the counts of autoboluses just within the first 2 months, and it sustained over time. But when we look at user-initiated bolus counts, it didn't change. So what does this tell us? It means that those people kept their eating behavior. Like if someone was, for example, someone was eating 3 meals before tirzepatide use, they kept eating those 3 meals. So they didn't change the number of user-initiated bolus counts. However, doses decreased. We can see that from here. When we look at the ratio of basal insulin to total daily dose, it also increased from 54% to 60%, 61, 63%. What does this tell us? It tells us reduction in bolus insulin was greater than reduction in basal insulin, so that we saw an increase in basal insulin to total daily insulin dose ratio. We also had carbohydrate data. So carbohydrate entry into the pump also decreased, with average carbohydrate consumption was 120 grams before tirzepatide use, and it decreased to 70 grams, 81, 66, and 45 grams in the following time periods after tirzepatide use. So to see the dose reduction in a clearer way, we prepared this figure. So as you can see, within the first 2 months, we saw a 30% reduction in total daily insulin and basal insulin. However, we saw a almost 45% decrease in bolus insulin just within the first 2 months. And I was keep telling that there was a further reduction there, and you can see here it in a clearer way. So this 30% reaches to 40% reduction, and this 45% also reaches almost to 60% reduction in the following months. So what is the clinical importance of this? It shows that those people who initiate tirzepatide, even with the lowest dose, they may need to reduce their insulin doses. Just after a couple of weeks, their initiation of tirzepatide. So automated insulin delivery system adjusts this in a good way. You know, it can handle basal part by itself, and people need to reduce the doses for meals and bolus insulins. However, this is quite significant and important for MDI users, multiple daily injection users. They should be aware that their insulin needs will decrease, and they should follow their insulin doses and their outcomes so that they should reduce doses, or their healthcare providers should reduce and follow their insulin doses accordingly. And here we shared time in range and time below range metrics. So as you can see, time in range was 70% at the baseline, and it increased to 80% in the 0 to 2 month period, and it sustained there over time. So AID system was already doing a good job there with 70% time in range at baseline. However, with tirzepatide use, it increased the glycemic management a step further with benefits, and it increased to 80%. And when we look at the time below range, it was quite similar. There was no significant change there. And we can say time below range sustained over time. So it didn't increase hypoglycemia risk in those individuals. And as my last slide for results, we also had glucose course over time. You can see at 24 hours here, starting from midnight throughout the day. We can say that from 3 a.m. to 6 a.m. period, there was no significant change there, because it's nighttime, people sleep, they don't eat, they don't exercise. So actually automated insulin delivery systems can handle those times if people basically do nothing. However, in the following hours, when they wake up and had their breakfast, after 9 a.m., we see a difference there. Because, when they eat, postprandial hyperglycemia becomes more prominent, and tirzepatide really helps with that. So we saw an important reduction there from a mean of 180 milligram per deciliter to 140 milligram. So to understand this postprandial benefits of tirzepatide, we collected glucose course after meals for up to 6 hours, as you can see. And here, it also decreased from 180 to 150s. So this is also meaningful, which means that this tirzepatide really affects postprandial glycemia, and it improves postprandial outcomes. So to sum up the second study, we can say that within the first 2 months, we see a reduction in both basal and bolus insulin doses, and reduction in bolus insulin was greater than reduction in basal insulin. So glycemic improvement is more prominent during daytime and postprandial periods. And we didn't see any increase in hypoglycemia metrics, which shows also a safe outcome, safe use of tirzepatide in type 1 diabetes. So with that, I can end my presentation and take questions. Thank you very much.
Thanks very much, Kagan. This was really interesting. I'll open it to questions. People can unmute themselves. Oops, sorry, a little bit off. They can unmute themselves, or they can raise their hand and ask a question, or drop something into the chat. Here's a question. Is there development of resistance, i.e. need for increased dose to maintain the same reduction in insulin bolus dose seen over time? Also, how often are people experiencing dose-limiting instances of gastroparesis or tachycardia?
I think those. So I can answer the first. I can start with the gastroparesis or tachycardia part. So people, so gastroparesis is a real issue, because in gastroparesis there's a delayed gastric emptying, and tirzepatide also delays even further gastric emptying. So it's actually not the dose, but the timing of the dose is more important for those people, because if they keep pre-bolusing, they will definitely have hypoglycemia first, because the increase in glucose level due to food intake won't match with the insulin course. So it's very important to warn patients for timing of insulin. They should even bolus after meals, to really match the effects of insulin and food intake. So it's very important. And is there a development of resistance? So what do you mean by this resistance, like need for increased dose, maintain the same reduction?
So,
So yeah.
hi, it's Alexis. That was my question.
Yeah.
I'm just wondering, you weren't able to, you said they were on a lot of different doses with time, and I assume that's as they could tolerate an increase in dose. But I'm wondering if someone stayed on the same, like a low dose, do they become more resistant with time to the effects of the medication?
Oh, I see. So actually, we didn't see that, but we also didn't see a further improvement as well. I mean, they usually showed the improvement in glycemia within the first 2 months, and they sustained over there. We couldn't see a further decrease in A1C or further increase in time in range. So they sustained there. They kept their time in range there. Uh, but
Kagan, did you relate their drop in insulin dose to what dose of drug they were using and find a relation to those two?
Like, do you mean by aspart or Humalog or those
No,
kind of?
not of the type of insulin, but the dose of the GLP that they were getting. Because some were
Oh,
on
I
lower
see.
doses, some were on higher doses.
We didn't do that analysis because the dosing was too complicated and too variable. So for each course of people's dosing for tirzepatide was unique, almost unique. They all started with 2.5. It was easy to see effect of 2.5 milligram within the first 3 months. However, after that, it was very variable and everyone was on different doses. That's why we couldn't do dose-dependent analysis. Unfortunately, that definitely requires a prospective study with larger groups to see dose-dependent improvement in glycemia or weight change.
Thank you.
Great. Then there's a question from Michael Haller. Are there any issues with insulin, insurance coverage in this population?
It's definitely the biggest issue currently. It's very, very hard. So usually, as I said, those people had obesity or they were overweight. So currently, FDA approved tirzepatide in type 2 diabetes and in obesity who had BMI over 30, or for people who had BMI over 27 with comorbidities. So those people usually have insulin resistance. So we show that. And we also mentioned type 2 diabetes diagnosis there. So with that, it usually helps with insurance companies. Uh, so, but it's a really big issue, and actually it's the most prominent problem with tirzepatide use in type 1 diabetes, I can say.
So yeah, is there a way do you see any way forward in pushing that issue?
So we don't have much proof or evidence for use of tirzepatide in type 1 diabetes. There are no prospective studies so far or RCT. So we definitely need some randomized controlled trials to prove the effect of tirzepatide, the improvement in type 1 diabetes population. So with that, maybe we can have some progress with insurance companies.
Yeah. I had a question for you regarding the reduction in bolus versus basal insulin and with tirzepatide. And the patients were intaking less carbs in the second study. That was kind of interesting. What do you think was driving that?
So we know that it decreases appetite and it increases satiety in people. So it really affects portions of people. So they really prefer smaller portions. That's why it really makes sense that their carbohydrate entries decreased significantly there.
But
So
do other parts of the diet, stay the same? Protein or fat in the diet? Has anyone looked at that, whether or not that distribution shifted, or was it just you think overall the portions decreased?
So we had this carbohydrate data because, this AID systems ask for carbohydrate amount to calculate doses.
Right.
That was the data we had. Unfortunately, we didn't have the data of their meals, what they eat, what was the, macronutrients in there. So
Mm-hmm.
unfortunately, I don't have a data to answer that questions. However, there are studies showing that it's actually people really prefer smaller meals, smaller portions in type 2 diabetes and obesity populations. Uh, so we can say they prefer smaller portions, including all macronutrients.
Right. Well, that's good news. I mean, you've got some good starting studies here to sort of advocate for changes in you know, the use of this drug in these patients. So that's it's really a good starting point. And are you going to move forward into, what's your next thing to do in this group, or will you just, are you going to do more studies with this group?
Yes, as I said, we definitely need a prospective study with a good result, good level of evidence for those people. So, and we need more studies, including, their glycemic outcomes and also long-term outcomes for cardioprotective and renal protective effects in type 1 diabetes populations. So, we are planning to see if there is any effect on, long-term outcomes regarding cardiovascular and renal outcomes for complications. That's one idea. So we'll see. It's a new field and there's
Yeah.
definitely a lot of attention there.
Yeah, there's a lot of potential there. Last question. Any thoughts on how much of the reduction in necessary bolus insulin can be attributed to simply consuming less carbohydrates as opposed to effects of insulin resistance?
Um, so this is actually a tricky part because we know that some people have really high insulin resistance in type 1 diabetes. It really changes individual basis. So we showed that there is a 30%, 40% reduction within the first 2 months. However, it doesn't be the case for everyone actually.
Mm-hmm.
So we should really evaluate patients individually. So some patients really don't need any reduction in insulin. Even if they have obesity, some patients don't have insulin resistance, so we don't see much reduction there. But sometimes we don't see much weight change. However, there is a huge insulin resistance there. So when we solve that problem, we can reduce the insulin doses like 30% easily within the first month, I can say.
Hmm.
So that's why I can say the amount of insulin reduction that's necessary for bolus insulin. And it's really, I can say both. There is there is definitely an interaction between less carbohydrates and insulin resistance. So it really changes at individual basis.
Yeah, maybe something to put into your next study design.
Yeah.
So, well, you've got a lot of accolades in the chat. Thank you very much for your nice talk from a few people. And we really appreciate you coming on today, Kagan, and sharing this important work. And can't wait to see how the next series of studies work out for you guys there at the Barbara Davis Center. So thanks again, and we'll talk to you soon, I hope. Have a great rest of your day.
Thank you very much. Have a good one.
Bye-bye.